I wanted to give my thoughts on sinusitis. Sinusitis, you can think of the duration. Less than 4 weeks, it's acute. Subacute is 4 weeks to 3 months. Chronic is greater than 3 months. Viral versus bacterial, the majority, greater than 90%, are going to be viral sources of sinusitis. The rest, bacteria, like 2% bacteria. Common pathogens you're going to see are strep pneumo, Haemophilus influenza, Moraxella catarrhalis, Staph aureus. The majority of sinusitis will go away on its own. There will be an 85% reduction and resolution of symptoms within 7 to 15 days just by doing nothing. However, for sinusitis, in the emergency room and outpatient settings, when you go to a doctor, 84% to 91% of individuals will get antibiotics. Why is there this discrepancy between a disease that seems to go away the majority of the time, 85% on its own, and the fact that we're giving antibiotics so much? Part of it comes from patient expectations. Patients expect you to give them something for coming into the hospital or coming into the doctor's office. They don't want to be told supportive care, nothing to do, just watch and wait. They want to have the assurance of having antibiotics. Also, there's some inconsistency with the guidelines. However, the majority of studies will support not giving antibiotics. So, if we look at the randomized control trials, if we look at the systematic reviews, it shows minimal efficacy of antibiotics. The studies had to look past 7 days, so 7 to 15 days, where they saw small effects of clinical improvement that is statistically significant for people with sinusitis receiving antibiotics. The number of people needed to treat to see this shortening is 18 patients. That means the majority of patients, let's say the first 17 patients you give antibiotics, most likely won't do anything. But probabilistically, 1 in 18 will see the benefit of the shortening of the symptoms. So think about this: 85% of the time, sinusitis will resolve on its own. And even if you give antibiotics, only like 5% of individuals will actually see the benefit. And the benefit is just shortening of the duration of symptoms. But you have to realize when you're giving antibiotics to shorten duration, there's also an adverse effect of the antibiotic that you have to weigh in. You have to weigh the pros and the cons. So the adverse effects being, for amoxicillin as the first line for sinusitis, there's allergic reactions, there's the rash. And when they did the studies, the number needed to harm is only 8 to 12. So in the 18 people that you're helping, 2 of them will get the adverse reaction of the rash, or like any, sometimes allergies are more severe, it can close up the airway. You're also not taking into account that unnecessary antibiotics increase drug resistance and actually make sinusitis a more difficult disease to face in the future. And the second line for people who can't tolerate amoxicillin is levofloxacin. And in those cases, you can have tendon rupture, which is not a complication that you would want. So, why do we give these antibiotics? We want to resolve the symptoms that the individuals have, and we also want to stop bacterial infections. Viral infections go away on their own, but bacterial infections can cause suppurative complications. This has to do with the inflammation that the body attacking the sinusitis has. So you can have stuff like cellulitis, meningitis. You can have orbital or intracranial abscesses. However, all the studies, the main theme being try, like pretty much you don't need to give antibiotics. A systematic review showed that in the group that got antibiotics and a group that didn't get antibiotics, the group that didn't get antibiotics, only 0.08% got this suppurative complication, this dreaded complication of sinusitis, and they got a meningeal abscess. So In the group, there was 1,211 individuals, so only 1 out of 1,211 got this complication, and there were none that got the complication in the group that received antibiotics. This is not a statistical significant difference. However, it is an emotional one because when you're talking to patients, you're saying in the group that didn't get antibiotics, one person got a complication. And that would scare anyone into wanting antibiotics because they don't weigh the risks as much as the marginal benefits. You have to think of sinusitis as a giving antibiotics and sinusitis as a major risk with marginal reward. So adverse events are lower for those who receive shorter course of treatment. So if you do end up giving antibiotics, you want to give less as opposed to more. And a lot of the times these are going to be 5 to 10 day treatments with amoxicillin, augmentin, doxycycline, or like a respiratory fluoroquinolone like levofloxacin. So aside from antibiotics, data and efficacy for decongestants such as pseudoephedrine, antihistamines such as azolastine and olapatadine, or guaf, which is a mucolytic agent, they're lacking. And there's really no major randomized control trials for these types of things. However, one did show that loratadine significantly reduced the incidence of sneezing and nasal obstruction. So I hope after listening to this, it gives you more of a sense of how you should be using antibiotics in sinusitis and how we can use evidence and data to better inform our decisions, but also be cautious of the different preconceived notions that people have about sinusitis.